Hello friends, and welcome to this video. In this video, we will talk about pulmonary embolism in detail. I hope you will find this video very useful. We have a lot to cover. So without further ado, let's start. Pulmonary embolism, or PE, is said to occur when some material from anywhere in the body passes into the pulmonary circulation and block blood flow to the lungs. This blockade of pulmonary circulation leads to multiple deleterious effects, depending upon onset, size, number, and distribution of embolic material. There is compromised gas exchange, which leads to hypoxemia. If the block is massive, it can cause circulatory compromise due to reduced cardiac output and acute right heart failure, leading to cardiogenic shock. In cases of small or medium PE, occlusion of the segmental pulmonary artery leads to pulmonary infarction and its sequelae. In case of recurrent or chronic occlusion of pulmonary microvasculature, pulmonary hypertension develops and leads to right heart failure. Causes. Most commonly, pulmonary embolisms arise from a deep venous thrombosis in the legs or pelvis. Clots from there break off and pass through the veins and then the right side of the heart, before lodging in the pulmonary circulation. The source of thrombus can often be occult. Rare causes of PE include right ventricular thrombus, for example post-right ventricular infarction. Septic emboli arising from endocarditis affecting the tricuspid or pulmonary valves. Fat embolism arising following fracture of long bones such as the femur. Air or amniotic fluid embolism as an obstetric complication. Neoplastic cells, especially choriocarcinoma. And rarely, parasites can also cause a pulmonary embolism. Causes of embolism other than thrombus have different management and are beyond the scope of this video. And for the sake of simplicity, we will focus on the most common form of pulmonary embolism, that is, embolism arising from venous thrombus. This form of embolism is also called venous thromboembolism, or VTE. Risk factors. Risk factors are the factors that make a person prone to develop thromboembolism. There are many risk factors that can contribute to VTE. Please note that the factors which contribute to deep venous thrombosis of the legs are also the risk factors for pulmonary embolism. If a patient diagnosed with VTE is having any of these risk factors, the VTE is said to be provoked. If there is no apparent risk factor, VTE is termed as unprovoked. A recognized risk factor is present in 80 to 90%. These factors include recent major surgery, especially abdominal or pelvic surgery, or hip or knee replacement. Prolonged bed rest. Immobility, for example due to leg cast, due to neurological conditions such as stroke, Guillain-Barré syndrome, or immobility during long-distance traveling of more than 4 hours duration. Thrombophilia, for example, antithrombin, protein C or S deficiency, and factor V Leiden, etc. Malignancy. Anti-cancer chemotherapy increases the risk of VTE compared with cancer alone. Nephrotic syndrome. Antiphospholipid syndrome. Myeloproliferative disorders like polycythemia rubra vera, essential thrombocythemia, and myelofibrosis. Paroxysmal nocturnal hemoglobinuria. Active inflammation, for example infection or inflammatory bowel disease. Pregnancy and the postpartum period. Estrogen-only or combined contraceptive pill. Hormone replacement therapy, and previous thromboembolism. Some of these risk factors alone, like the use of hormone replacement therapy, may not lead to thromboembolism, but increase the VTE risk, if combined with another factor, for example immobility or major surgery. What are the clinical features? Presentation of VTE depends on the onset, number, size and distribution of emboli, along with underlying cardiorespiratory reserve. Small emboli may be asymptomatic, whereas large emboli are often fatal. So, the presentation can be anywhere on this spectrum. Symptoms of PE include acute breathlessness, pleuritic chest pain, hemoptysis, dizziness, and syncope. The patient may be currently having DVT legs that make the diagnosis of PE pretty straightforward. In other cases, ask about risk factors and past or family history of thromboembolism. Signs also depends on whether PE is acute or chronic, and whether there is massive PE or not. We will enumerate, however, all the signs that can be found in PE to keep it simple. Signs include tachypnea, tachycardia, hypotension, cyanosis, raised JVP, right ventricular heave, loud P2, gallop rhythm, pleural rub, pleural effusion, and sometimes atrial fibrillation. Also, look for sources of emboli, especially deep vein thrombosis. Assessment and investigations. Diagnosis of PE is improved by adopting a stepwise approach. This is done by doing an objective probability score with subsequent investigations. If the patient is hemodynamically stable, calculate the probability score of PE. Many scoring systems exist, and one of the most frequently used is modified Wells criteria. Let's explore this score. See if there are clinical signs and symptoms of DVT. If yes, give 3 points. If the heart rate is greater than 100 beats per minute, give 1.5 points. If the patient is recently bedridden for more than 3 days, or if he or she underwent major surgery within the last 4 weeks, score at 1.5. If there is a previous DVT or PE history, score at 1.5. If the patient has hemoptysis, put a 1 score. If the patient is having cancer, receiving active treatment, treated in the last 6 months, or on palliative treatment, mark it 1. And lastly, see if an alternative diagnosis is less likely than PE. The score for this criteria will be 3. Now calculate total score. If the score is 4 or less, PE is unlikely. And if the score is more than 4, PE is likely. If the score is 4 or less, then do a D-dimer. Serum D-dimer has low specificity, meaning that an elevated D-dimer may be raised in a variety of other conditions, including myocardial infarction, pneumonia, and sepsis, and therefore is of limited value. However, in the patients whose modified Wells scoring falls in the unlikely PE category, a negative D-dimer has a high negative predictive value. And therefore, a negative D-dimer here effectively excludes PE, and further investigations are usually unnecessary. On the other hand, the result of the D-dimer assay should be disregarded in high-risk patients, as further investigation is mandatory even if D-dimers are normal. CT pulmonary angiography is a sensitive and specific test. It is the test of choice for high-risk patients or low-risk patients with a positive D-dimer. It helps in confirming or excluding the diagnosis of PE. It also helps show the distribution and extent of the emboli or highlight an alternative diagnosis, such as consolidation, pneumothorax, or aortic dissection. As the contrast media may be nephrotoxic, care must be taken in patients with renal impairment, and CTPA avoided in those with a history of allergy to iodinated contrast media. In these cases where CTPA is contraindicated, either a ventilation perfusion scan or a ventilation perfusion single-photon emission computed tomography scan may be considered to establish the diagnosis of PE. A number of other investigations can be done. These tests are done to aid in the diagnosis or management, can show the effects of PE, may reveal the cause of PE, or may identify an alternate differential diagnosis. These tests include full blood counts, urea, electrolytes, and baseline clotting. Arterial blood gases may show reduced PO2 and increased alveolar arterial oxygen gradient, indicating poor gas exchange. Decreased carbon dioxide partial pressure and raised pH indicate hyperventilation, which has led to respiratory alkalosis. Metabolic acidosis may be seen in acute massive PE with circulatory collapse. Imaging. Chest X-ray may be normal or show peripheral oligemia of the affected segment, dilated pulmonary artery, linear atelectasis, small pleural effusion, or you may see a wedge-shaped area of infarction. ECG may be normal, but it is useful in excluding other important differential diagnoses, such as acute myocardial infarction and pericarditis. The most common ECG findings in PE include sinus tachycardia and anterior T-wave inversion, but these are nonspecific. Larger emboli can lead to right ventricular strain, evident by right bundle branch block, right axis deviation, dominant R wave, and inverted T waves in leads V1 to V3. The classical ECG pattern of PE, that is S1Q3T3, is rare. S1Q3T3 means deep S waves in lead 1, and Q waves along with inverted T waves in lead 3. Sometimes ECG may show atrial fibrillation as a consequence of PE. Color Doppler ultrasound of the leg veins may be used in patients with suspected PE, particularly if there are clinical signs of DVT. In critically ill patients, bedside echocardiography is extremely helpful in the differential diagnosis and assessment of acute circulatory collapse. Acute dilatation of the right heart is usually present in massive PE. A thrombus, which is an embolism in transit, may be visible. It also helps in identifying or excluding important differential diagnoses, such as left ventricular failure, aortic dissection, and pericardial tamponade. Conventional pulmonary angiography is still useful in selected settings, or for the delivery of catheter-based therapies. In patients with unprovoked PE, consider investigating for possible underlying malignancy. Take a full history, do a thorough examination, including breast, do chest X-ray, full blood count, calcium, liver function tests, and urinalysis. In patients greater than 40 years old, consider abdomen pelvic CT scan and mammography in women. Consider antiphospholipid and thrombophilia testing if family history is positive. Treatment. If the patient is hemodynamically unstable, thrombolyze for massive PE. Give injection alteplase 10 mg IV over 1 minute stat, followed by 90 mg IV infusion over 2 hours. Surgical pulmonary embolectomy may be considered in selected cases, but it carries a high mortality. Supplemental oxygen is given to hypoxemic patients to maintain oxygen sats greater than 90%. Circulatory shock should be treated with IV fluids or plasma expanders. Vasopressors, such as dobutamine and norepinephrine, can then be added if needed. Diuretics and vasodilators should be avoided, as they will reduce cardiac output. Opiates may relieve pain and distress, but are used with caution in hypotensive patients. Sometimes, external cardiac massage in a moribund patient may be successful by dislodging and breaking up a large central embolus. In hemodynamically stable patients, start low molecular weight heparin. Use unfractionated heparin if there is underlying renal impairment. Treat for 5 days with either type of heparin. Then to continue anticoagulation, you can start either warfarin or direct oral anticoagulant. If warfarin is selected, it needs to be overlapped with heparin, because warfarin has an initial prothrombotic effect due to depletion of protein C and S. The effect of warfarin is measured by measuring INR. Target INR in DVT and PE is 2 to 3. Once INR is established above 2 for more than 24 hours, you can stop heparin. On the other hand, if you choose to start direct oral anticoagulants, such as apixaban or rivaroxaban, etc., unlike in the case of warfarin, heparin is switched over to direct oral anticoagulants without the need to overlap both. Alternative to the initial use of heparin, patients can be treated with a direct oral anticoagulant even from the very start. It should be noted, however, that direct oral anticoagulants are not suitable for the treatment of hemodynamically unstable pulmonary embolism, massive iliofemoral deep vein thrombosis, those who are pregnant, or those with severe renal insufficiency. In cases where you can use these, rivaroxaban and apixaban may be used immediately from diagnosis, without the need for initial low molecular weight heparin. Whereas, the licenses for dabigatran and edoxaban include initial treatment with low molecular weight heparin for a minimum of 5 days, before commencing the direct oral anticoagulants. What is the optimal length of anticoagulation? Beyond the initial anticoagulation, long-term or maintenance anticoagulant therapy for VTE is administered for a finite period of 3 to 6 months. In cases of provoked VTE, it is 3 months. Then reassess the risk-to-benefit profile. Further continuation beyond 3 months depends on whether the risk factor persists. For patients with a provoked VTE, who have persistent but reversible risk factors, for example continued estrogen use or prolonged immobility following trauma, instead of stopping anticoagulation at 3 months, it is suggested to extend anticoagulation for a finite period. For patients with unprovoked VTE, the optimum duration of anticoagulation can be difficult to establish. Several factors predict the risk of recurrence following an episode of unprovoked VTE. The strongest predictors of recurrence are male sex, and a positive D-dimer measured 1 month after stopping anticoagulant therapy. These factors are incorporated into scoring systems to predict recurrences, such as the DASH score and the Vienna prediction model. In patients with recurrent unprovoked VTE, indefinite anticoagulation is beneficial. In malignancy, continue treatment with low molecular weight heparin for 6 months, or until cure of cancer. In patients with active cancer and VTE, there is evidence that maintenance anticoagulation with low molecular weight heparin instead of warfarin is associated with a lower recurrence rate. In pregnancy, low molecular weight heparin is continued until delivery or end of pregnancy. In cases where anticoagulation is contraindicated, or patients who have either suffered a massive hemorrhage on anticoagulation or recurrent VTE despite anticoagulation, consider the placement of an inferior vena cava filter. Retrievable inferior vena cava filters are particularly useful in individuals with temporary risk factors. The inferior vena cava filter should be used only until anticoagulation can be safely initiated, at which time the filter should be removed if possible. Prognosis. Immediate mortality is greatest in those with echocardiographic evidence of right ventricular dysfunction or cardiogenic shock. However, once anticoagulation is commenced, the risk of mortality rapidly falls. Recurrence risk is highest in the first 6 to 12 months after the initial event. Prevention. VTE risk assessment should be done of all the admitted patients, and appropriate VTE prophylactic measures should be put in place. For example, if prophylaxis is indicated, give prophylactic anticoagulation. In case anticoagulation poses a bleeding risk, mechanical devices like intermittent pneumatic compression, graduated foot stockings, or mechanical foot pumps should be used to prevent venous thrombosis. Stop hormone replacement therapy and the combined contraceptive pills preoperatively. And early postoperative mobilization of the patient should be done. And that's it for this video. Thanks for watching. Visit the channel and explore more medical videos. Consider subscribing to this channel to get the latest video notifications and spread the news about this resource to your colleagues as well.